Welcome to the August 2014 Connell Seminar Series, Southwest Missouri's 8th Annual Work Comp Conference. Our first speaker is Dr. Randy Cross, speaking on 21st century IT trends in medicine. Introducing Dr. Cross is Connell Insurance partner, Randall Gamble.
I would like to introduce Dr. Randy Cross. Dr. Cross has been practicing occupational medicine since 1994. He's been in the Branson area part-time and full-time ever since then, so that's literally 20 years this year. I started with a division of work comp in 1992, so I was only around for a couple of years, so it seems like I don't even remember time before Dr. Cross was practicing and working with employers in the area. And he's going to discuss a lot of updates, things going on in medicine, things going on in work comp, typical cases, things he sees. A lot of questions. If you have a question, raise your hand. We'll get your questions addressed. And he's also going to discuss video telemedicine type product or type service that Cox is now offering, which is going to be very helpful, I think, for a lot of you in this area, and especially in the Branson area, because you know the way traffic is in the summertime. You may be on the other end of Branson. It's just a huge inconvenience to get here. You may be spread out. You have multiple locations. You may have the bulk of your operations here and one small location an hour away and so forth. So it's really, really handy if you can use the same physician. So some of those services will be very, very appealing to you. But again, with no further ado, I'd like to introduce Dr. Randy Cross with Cox Work Med program.
All right, thank you. I just want to let you know, if you haven't been here before or seen a microphone like this, I'm not sure if I should sing like Garth Brooks or if I should try to sell you a sham wow or something like that. But anyway, and this is truly interactive as I go through this. I want to give you some information, but also I want to try to be here to answer any questions that you have. So as the slides come up, if you have a question, go ahead and raise your hand. Randall's going to have a microphone. He's going to kind of be roaming around. At the end, we're going to have a good question and answer session as well. But if something's really on your mind and a particular slide triggers that thought and you don't want to let it go, or you're like me, if you don't say it right away, you'll forget, then go ahead and raise your hand and we'll try to cover those questions. What we're talking about right today is something that's relatively new and different. And I was just visiting with Isaac Coward a little bit earlier. I've been doing this now since '94, so this is 20 years I've just been doing occupational medicine. Prior to that, I delivered babies and did sports medicine and used to do lots of colonoscopies, and it was in primary care in a small rural town, so we did everything back then, surgeries and whatnot. But when I got into occupational medicine, I remember first coming to Branson and setting up the clinic here with my wife as the nurse and the office manager. It was just the two of us. And that was in the day back in '96 when there were some business owners in town that would actually fire people when they got hurt. And we've come a long way since then. And in visiting with Isaac, I was just mentioning the amazing thing as we go to more and more of these seminars through the years, as we've tried to impart information to our audiences with our orthopedic summit, with our spine summits and that sort of thing, is how savvy the crowd has gotten. You know just about as much as I do now, or maybe more in a lot of areas, and it's harder and harder for us to give you intelligent answers to your questions. So that's hats off to you for actually learning the business of workers' compensation and the insurance industry so well and doing such a good job with your clients. I do want to thank the sponsors here. Tim Connell and his two partners, Randall Gamble and Mike is back here too, for putting on a good seminar. We do appreciate people that are trying to take good care of the workers in Missouri, and I think Missouri is a great place to be. We have tremendous quality of businesses here, some of the leading businesses in the nation centered right here in the state of Missouri, some of them right here in the Ozarks, and that's a real feather in our cap. All right, as we go through this, let me turn this around. I'll use the pointer. Now, what we're talking about today is actually a 21st century innovation. As we've gotten more and more technology, we realize we have to make good use of this technology for a couple of reasons. One, in our area of expertise, it's hard for us to be in all these small locations around the country to be able to give people to good quality care and even triage in terms of their work comp injuries. So what we have launched this year, first a pilot that started in January, something that we call OcMedStat, which is our version of telemedicine. Now, telemedicine has actually been going on for quite some time, and some people say as many as half of U.S. hospitals have some form of telemedicine. Basically, what we're doing is we're using high-speed internet connections with high-definition video cameras and good audio in order to be able to meet with a patient face-to-face through the high-speed internet connection and get good information to them from a medical standpoint, answer questions, help to triage them into appropriate level of care. And we were not doing so much of that here in Springfield, but we talked about why couldn't we use this in occupational medicine to allow us to be present in a lot of the smaller communities by that modality. So we launched this pilot, and we actually started checking around, and we think that we're probably the first and only group that's done this in occupational medicine in the whole country. It's being done in the area of psychiatry, and that works really well in psychiatry. It's been done in the area of primary care medicine, and a lot of the specialists now can meet with people in rural areas, but this is the first that we know of being done in occupational medicine. And the estimate is you're talking about 4 short years or 3.5 short years, estimate of 7 million visits worldwide that will be done by telemedicine. You know, I thought it was phenomenal when they had Da Vinci surgery. You have a patient on the table here across the room. You have a doctor sitting at a console that looks like a video arcade game, and he's manipulating little gadgets that are inside of that patient's belly. And, you know, that's phenomenal. And with appropriate link up, he could actually be in another state operating on that patient. You know, that's the technology that we have. So if you think about where we've come and where we're going, that's even more phenomenal. What will happen in the future? Telemedicine is a big part of that innovation. The AMA says that 70% of doctor visits could probably be handled over the phone. That's not to cut us out of a revenue stream or anything, but you know, oftentimes people are so busy they can't take a lot of valuable time out of their schedule to come in and sit and wait in the waiting room around sick people. So that we think that telemedicine is going to afford the opportunity for people to still get good quality care without having to take that time out of their schedule at work. Now, this is interactive. By its very nature. And there's just, we think it's unparalleled access because the fact that you can get an expert opinion in West Plains or at Lake of the Ozarks or over in Joplin or down in Harrison, Arkansas with somebody that can see your patient and interact with them. It allows the critical decision making to be done within minutes of an injury in the workplace instead of the next day or instead of later that same day. And that's a great, great innovation. The quicker that we can get people into a professional to have an evaluation and get appropriate treatment started, the less likely you're going to have a lost time injury or the less likely you're going to have a significant loss of production in the workplace. And also the revenue stream for the employee continues. So it's definitely a win-win-win situation all around. What this does, and this is important for you to realize, out in the workplace, a lot of times you have decisions that are being made by, say, the evening supervisor who may have helped his son get his first aid merit badge. Maybe that's the only medical training they have, you know, as a Boy Scout or something. Or you may have first responders in the workplace. Some of you are fortunate enough you might have an LPN on staff or an RN on staff at some of your businesses. And we're not trying to take away their job at all. What we're trying to do is supplement what they can do in the workplace by giving them the ability to get some expertise and trying to make a critical decision early on about what level of care needs to be rendered. This delivers a recommended action that's consistent with work comp laws because you do have a workers' compensation professional involved in the decision making, and we're not going to steer you wrong and have you do something with your employee that would get you in violation of any kind of HIPAA laws or OSHA laws. So from that regard, it's nice to have the expertise available. It's going to reduce some unnecessary utilization and things that are extremely expensive now. You just about can't walk into an emergency room without the basic minimum $400 emergency room charge, and then everything from there goes up. Any kind of testing that's done, and any kind of supplies that are used, the $5 for an aspirin and that sort of thing. So here we are talking about cutting costs that are going to help your bottom line, and that definitely is a win-win situation. A lot of urgent cares are offering extended hours now, so that's always an option. And what we're trying to do is partner with emergency rooms, urgent cares, and also primary care physicians in a lot of these rural communities to be able to offer that service or get your patient to the appropriate level of service so that you're spending the right amount of healthcare dollars and not excessively overspending healthcare dollars. It keeps the employee on the site, eliminating the time that they're away from work and also the travel expenses if you're paying them mileage. It also keeps the supervisor on site so he doesn't have to come with the employee to the hospital to be seen. Frontline staff are there as well, so productivity stays very, very high. Provides the employees with the peace of mind and the understanding that you care about them enough that you got a physician's opinion right up front with their injury. And also they know that they have actually visited with a doctor, even though it was by a computer link-up, but they feel that they've had the chance to interact with the physician to voice their concerns, and instead of just a third party through your supervisor, calling and talking to the doctor. And then it improves this level of communication, and that's where we feel that this really is a viable option for us in the workplace. The employees involved, the employers involved, the physicians involved, we get more quick involvement with physical therapists. We have quicker involvement with case managers if necessary, all for the purpose of trying to streamline the process and make it more efficient. These are some of the companies that we have been partnering with so far. We originally launched our pilot with PenMac down in West Plains, and the reason being is they had so many people that were an hour and a half away from us in Springfield, and that was fortunately it was a great experience with the pilot. And our first injury was actually an eye injury that we were able to look at with the high definition camera, and we could see it beautifully. So we've gone on to add additional ones. Sight and Sound Theater right down here in Branson has shows at 3 o'clock and 8 o'clock, and so most people get hurt after the show starts about the time we're closing our office for business. And so they said, well, what are we going to do after hours? And so they like the concept of telemedicine, and you'll see a little bit later how we're working on trying to extend that into later hours in the evening. Some examples of very appropriate telemedicine visits would be something superficial, scrape or a cut. And even with the camera, we can ask the patient to sort of spread the area apart. We can see how deep the lesion is, if it looks like it's going to need stitches, or if it's something that can have a Band-Aid or steri strips. Corneal abrasions that as I mentioned, we've seen. Even soft tissue injuries such as muscle strains and sprains. If there's an obvious deformity, we may say, gee, this looks like it might need an x-ray. There's probably something more than just a muscle strain. But discolorations in the skin such as bruising or redness, rashes on the skin. We've seen chemical burns. We've seen contact dermatitis. Minor burns that are just either red or blistered. Of course, if it's full thickness, we want those into the burn center or into the physician quickly. And then even allergic reactions to chemicals in the workplace or to medications that someone may have taken, or an exposure to an allergen. Any questions? Yes? We have lots of different options there. If you have a company, the question was, what if they need a brace or something for a sprain? If there's a durable medical equipment place in your town or one of your pharmacies that handles those, we can immediately call the pharmacy. We can get a prescription medicine, or we can get a brace if needed, or we can get a cane, we can get a rollabout, we can get crutches.
It totally eliminates the need for them to go into the physician based upon the outcome of the
That's possible, and we can. If a company's large enough, maybe you even want to keep a few things on site. Wrist braces, or an ankle brace, or ACE wraps, or crutches, or something like that. So, this can get it can be as small as just a consult, or it can be as big as helping us to guide you in some treatment areas if you have some people on staff that are trained. We do have to keep people on your location within their scope of expertise. So if they're only trained as a first responder, we'll only guide them in doing some first aid type things. Yes, ma'am. Now that we're having to work on with each location. What we're trying to do in some locations where we have primary care physicians in the area is see if we can get some of their personnel trained so that you could go by and just do the drug screen at their office. Or if you have an urgent care, we're working with some urgent cares, and we do that in Springfield as well. All you do is you just show up and get the drug screen. You don't get signed in. You're not going to get treated and charged like you're an urgent care or an ER patient. All you're getting is the drug screen or that breath alcohol. Some people even are trained to do some of the quick test, and we can assist you with different agencies that will certify your people to be urine collectors, and you can do the dipstick test, as a screen. Of course, if you get a non-negative on those still need to be sent off. So then you have to be trained on appropriate completion of the chain of custody form, and then usually we set up accounts where you just have that picked up by UPS or FedEx, and they'll take them right to the lab. So that's a good question. Anybody else? All right, let's move along. Now, this is what we've done so far. Up through June of 2014, we had 30 visits through OcMedStat as part of our pilot program. None of them required any off-site treatment. Now, we anticipate as this grows, some will require some off-site treatment, but many of these we were able to do with only maybe one office visit, or most of them actually with no office visits. We did the initial OcMedStat visit, and then we did a follow-up visit, or maybe 2 follow-up visits by OcMedStat, and we were able to close the case. Now, we treat this just like we would any other visit. There's still documentation, and so we'll still make a full office note that will be either dictated or done electronically, and that's maintained as a medical record. So we're not violating any rules or regulations with regard to OSHA. Oftentimes these things can be non-recordables for you all if it just turns out to be a first aid type treatment, and we'll try to direct you on those areas that are non-recordable, which also can help you in your insurance mod ratings and that sort of thing. We've seen muscle strains and sprains, foreign matter in the eye, minor cuts and contusions, and we've delivered services in all 4 of these locations so far. And here's basically how it works in a nutshell. We have someone in your workplace that assesses the injury. Usually it will be a supervisor or a first responder or the company nurse. Then they initiate the call by calling a single 1-800 number that puts you in touch with our sort of our clearinghouse for OcMedStat. Once that's been initiated, we have a little bit of paperwork that you fill out on your end that gives a history of the injury, and then you log into your account if you've been set up as one of our clients. You'll have a computer with a high-definition camera, and we'll talk a little bit later about costs on that. But once you're logged in, the physician on the other end picks up the video and audio links established. We spend a little bit of time with the supervisor and the employee together in the room, and then once the visit starts, the supervisor leaves, and just the employee and the physician are involved, so there's no violation of Health Information Patient Portability Act or HIPAA rules. And then after the visit is completed, the supervisor comes back in. We sort of recap what we think the problem is and what the treatment plan of action is going to be, and then we immediately complete on our end a report to employer that we can either fax to you by conventional fax machine, or we can even e-fax. And so you get the report just like the patient had come to the office. Now, we do want to emphasize this is for non-emergent injuries. Things that are emergent injuries that are not appropriate for OcMedStat. If somebody has a head injury where they're going to need assessment to see if they have potential brain injury or brain damage, concussions, that sort of thing, that needs to be at a higher level of service. Chest pain, if there's a possibility of cardiac issues, we don't want to be, taking our best guess as to whether this is a heart problem or a lung problem or whatever. Where someone's acutely short of breath and might need respiratory support. Third-degree burns where they're probably going to need extensive debridement and then eventual skin grafting. And then lacerations where you can actually see deeply down into the tissues. If it's beyond the dermis, then those do need to see someone to get sutured, and we'll try to help you with that to get to the right location for appropriate suturing. This is our base number. 269-3813, and you notify the OcMedStat coordinator that answers the phone that you're going to have an injured worker that's going to need to be assessed. What we're doing right now is we're routing that to the doctor that's got an open spot in their schedule that can get to it the quickest. And this is basically what it looks like on your computer screen. This is a screenshot. Up here will be the site number and their identifier. This is the software that we use for this. We looked at several different software programs, and we determined that video was actually the most user-friendly for us and for our clients. So we just select from the list or enter a name to call, and then once you initiate that call, our computer starts to ring. We hit the answer button, we join the room, and then this becomes a big TV screen. We've got the patient up here, and down in the lower corner you'll be able to see what you're sending to us. There'll be it's a picture-in-picture type setup, so you'll be able to see down the bottom what you're sending to us, and then we'll be able to see what we're sending back to you. Now the visit occurs, as I mentioned, with the supervisor in the room initially, and that helps us to establish what the mechanism of injury was from two standpoints. One is what the employee tells us happened. Two is any observations that the supervisor might have from witnesses about the actual mechanism of the injury. And that really, taking a good history is about 80% of the most important aspect of a visit anyway. If you get a good history and you have a good mechanism of what happened, a good understanding of how that occurred, you can come up with a diagnosis quite easily that way. The supervisor then reviews the events with the provider. The provider will review any medical history that might be relevant. If the person's, for instance, a diabetic, if they're on blood pressure medicine, if they have other medical conditions that might be relevant to the injury, then we do review that. And then we do that with the patient only, so there's no HIPAA violations there. And then once the visit occurs, we'll review the plan of care with the patient and the supervisor that comes back into the room so that we're all on the same page as to what we're going to do with this patient and the appropriate level of the care that'll be rendered. Patient often returns to work, but within the hour. Maybe some first responder activity has occurred. Maybe a dressing's been put on, or a little bit of ointment or something like that. The physician goes on and does the notes and the dictation. The invoice for service is generated, the report to employer is sent, and then the billing process starts for all of that, and you've got a nice conclusion to a very efficient process. Now this is a little video Dr. Qureshi's going to show you.
Hi, my name is Dr. Anjem Qureshi from Cox Health Occupational Medicine, and today I'm going to introduce two common injuries we see through telemedicine.
Hi, this is Max, our patient, and he injured his back at work today. So the first thing we want to find out is where Max is hurting. So Max, go ahead and tell us the location of your pain. Very good. And then the next thing we want to do is we want to check his range of motion. So I'm going to have Max bend forward. Go ahead, Max, bend forward and stop when it hurts you. Good. And go ahead and come back up. And then I want you to do a lateral rotation where I want you to turn to one side as far as you can and then turn to the other side as far as you can. Again, I'm checking for symmetry here. And the other thing I want you to do, Max, now is I want you to do a lateral flexion where you're going to touch your ankle from the side. So go ahead and bend over to the side there. There you go. And then the other side. So this kind of tells me where he has inflammation and where he has restrictive movement. And this is part of our muscular exam. And then the next thing we're going to do is we're going to check to see if he has any nerve root impingement issues. So go ahead and lay on your back, Max. And I'm going to have you elevate your left leg up as high as you can and tell me if there is any pain at all. Go ahead. Good. And go ahead and elevate your other leg. Good. So this exam right here would tell me if he had a pinched nerve in his back. So it would help me demarcate the between muscular and nerve root issues. In this exam, we want to show you the detail that our camera can pick up. So from this vantage point, you can see that the laceration is superficial, but you really can't see the depth or the extent of it. So now we're going to move the camera closer. And here you can clearly see the depth of this laceration and the width. And from this, I can clearly advise that this is a laceration that would not need to go to the urgent care, that we could easily treat it with some antibiotics and local wound care.
From the two brief encounters I shared with you today, I hope you're able to better understand how we can use telemedicine to offer the best care for your employees. On behalf of Cox Health, thank you for joining us.
Now there would be more, that's just a kind of a basic thumbnail sketch there, but there would be a lot more interaction. We would actually have audio there so that the patient could say, oh, as I bring my leg and I get up about 45 degrees, now I've got pain going down into the back of my leg, through my bottom, into my left calf or right calf or something like that. So Max was a little shy. He didn't want to say too much in that portion of the video, but it is quite interactive, and we've had great feedback from all of our patients so far with this, and we're finding that they seem to like the fact that they can talk to a doctor right away in this mode. Now we are working on putting together a call schedule where we'll be able to offer this coverage after hours, after our usual office hours, from 5 in the afternoon till maybe as late as 11 at night, and even on weekends, which will get you coverage for second shift workers. The other aspect of this is what we're calling our sick call for right now, Cox Health Connect Care. And we actually had a business here in the Branson area that approached us about this. White River Electric came to us and they said, is there anything that we could do where we could try to keep our employees from missing work when they have a sick child? For instance, the secretary, they wake up in the morning and their daughter comes in and she says, I got a bad sore throat and a fever, and oftentimes they can't get into their primary care doctor, or it's too early for urgent care. And so anyway, we considered that solution, and we're partnering with our regional services department at Cox Health, which includes all of our primary care clinics, to be able to initially do a telemedicine visit with one of our physicians, but branch out and have sick call. And what that'll do then is it'll get, for instance, treatment for a strep throat. It'll get us started immediately that morning instead of waiting till a day or two later when you can get into the doctor. And if we get the child on antibiotics quickly, they're going to be better much faster, and that way your employee is not going to miss as much time from work trying to care for their sick child. So we see this as a tremendous potential, and not only for injured workers, but also for just ill individuals with minor illnesses. We're also partnering with our wellness department through corporate wellness, and we think that we're going to be able to offer, for instance, a dietitian, being on site with your people by telemedicine link up to talk to you about healthy living, good eating choices. We also maybe have someone such as Isaac who'd be happy to get on there and do a little sports medicine talk. Okay, here's some good stretching techniques and some things for prevention of carpal tunnel type problems in the workplace. So we see this as being able to expand in the future, where if you have the capability on your end of projecting what comes over a computer, which is so easy to do with one of these projectors, you could have safety seminars in your workplace without your people having to leave and go to a venue like this. Maybe even these very conferences like this in the future are all going to be linked up just by telemedicine. You'll sit in the comfort of your office or your home in your pajamas, and you'll be listening to Randall talk to you about insurance without even having to come. Of course, you'll miss the breakfast, but we just see there's such a potential here. All right, do we have questions? Now, Randall's going to go around with the microphone, and we're going to try to answer as many questions as we can about this. Probably one that I get a lot is, how much is this going to cost? And it's amazingly economical. We've looked at the software and the hardware both, and the whole package put together to come to your place and set up a high-definition camera that can be on a laptop computer or on a PC. And with the software by video, it's like less than $500. Pretty amazing. And then what we're doing is we're partnering with people to set up the account. And once you set up the account, we're trying to determine what our fee schedule is going to be for a visit, and just a flat fee for a visit, no matter what severity. And then the other aspect is partnering with people in the local communities, whether it be urgent care, ER, primary care office, if it's not close to Springfield or not close to Branson or not close to Lebanon, where we have our offices, where you can get the higher level of care if it's necessary. And of course, that would be a different charge, you know, if you see someone else. But basically, it's looking like it's extremely economical. Yes, ma'am. Right. She's asking, once we have that equipment for occupational med or OcMed Stat, would we be able to expand to the other services like the Connect Care and you know, the corporate wellness? Absolutely. Now, the only thing you might need additionally on your end is, instead of this coming in just to a computer, you can actually come into either a projector like this to project it on the wall if you want to have a big conference, or you could link it to more than one computer if you want to network your computers. Now, we're not going to do that with the OcMed Stat visits. You know, we still want to maintain patient privacy and integrity, but everything else I think would be just great. Yes, ma'am, way back there. You know, wait just a second. Randall will give you a...
Actually, I'll just repeat the question.
All right.
Don't be scared. I'm not going to ask you to speak into the microphone, but we want to repeat the question so we get it on a recording
Okay.
for the folks that watch it as a webinar or a recording. But yes, question?
Well, that still is in its infancy, but you know, we think that we will be able to offer those sort of things at a nominal cost. You know, they would certainly be cheaper than taking all of your employees out of production to go to a seminar. You'll have, you know, just an expert on our end that will, it may be like an hourly rate or something like that, just to offer a safety seminar.
So basically the question real quick was, is if the employer puts the equipment into their workplace, what all can they utilize it, or can they utilize it for other things? And the answer is yes, correct?
Yes, they would be able to use that.
Right.
Yes, sir. Well, what we're seeing on our end, you know, with us trying to do this call schedule, we take these calls on our iPads or our iPhone or an iMac Air or an Apple computer at home. Now, we have found that it's a little bit better quality if it's you know, like a high-speed internet connection as opposed to just Wi-Fi. But the good thing about video, if you have video on your end and our end, it is encrypted, so nobody can get in there and it stays secure. But if sometimes Wi-Fi coverage depends on where you are and what your service provider has. If the quality is not the greatest, sometimes it might drop out a little bit and it'll be kind of jumpy. So we like the wired connections because we can guarantee that we're not going to drop the call. But on our end, we're using iPads a lot, and it's great for us because all we have to do is be within sight of a good Wi-Fi source, and we can do one of these visits. With the encryption with video, the software that we use, it can't be intercepted because it's all scrambled. Now, we wouldn't take a call and say Panera Bread, you know, sitting there with our iPad, because other people would get to see the patient. That would violate HIPAA. So, you know, we'll get off somewhere in like a separate room or something where it can be, where it can still be confidential. Or we take these at home, and you know, we're still working on all the details as we get more staff, because we anticipate being able to hire or having to hire, you know, in the future maybe even 2 or 3 people to do nothing but telemedicine. That's a good question. It would depend on the tiering of your health insurance, because if you want to build that as a health insurance model, then if the Cox provider is in your network, it'll be just like a network visit. You know, we'll have set up the pricing of that. Some of the companies that we talked to about doing the pilot said, we want to just pay for the visit out of the company resources, because it keeps our employee on the job and more productive. And so they've offered to do that as we go through the pilot stage of the Connect Care part of this telemedicine.
One observation on that is that some of the larger employers, especially in the Springfield area, that actually have physicians and nurses on staff and like a little more than a first aid station, this would to some extent allow an employer to do that. Almost as if you've got your room set up with the equipment, with the connection, everything set up the way it needs to be, that it could be utilized almost like having your physician or nurse practitioner there at all times, right?
For many of you right now, at your local Walmart, you may have a Cox-affiliated nurse practitioner in a little walk-in clinic, and they have a specific set scope of services. But this would be similar to that, and we may even have some of the nurse practitioners at the Walmart being some of our telemedicine, or not telemedicine for OcMedStat, but for Connect Care, they may even be the people that might end up fielding some of these calls. So that, it's just an extension of expertise, through a great medium, and it's going to be timely. We really do see a win-win for everybody with this. That's all you need is just have the appropriate software. If you have a high-def camera and you have audio capability, then we can just add the software. Well, we've looked into that, and we actually visited with administrative law judges on the legality of being able to do this. And right now, with other places that do telemedicine, you have to be licensed in the state in which the care is being rendered. So if we have somebody in, say, Harrison, Arkansas, one of our physicians, well, I am licensed in Arkansas, but one of our physicians that handles that call has to be licensed in Arkansas for that to be legal. No, we haven't. We're trying to make sure that we stay totally above the law. We're not even going to get into a gray zone with this. Now, the interesting thing too, which we've just recently done, they have all kinds of great devices, and we're starting to purchase these that have USB connections. So this week, either this week or this month, we're going to be getting an ear scope that will hook by USB port to our to a laptop or to a PC, where they can just stick that speculum right in the ear, and we can look for ear infections or foreign bodies in the ear or perforated eardrum. And they've got other devices. You can have digital stethoscope that you can hook in by USB, so they can hold that to the chest. We can hear the heart sounds. They're already doing this now in obstetrics, and I wish they would have. I'd probably still be delivering babies as I did my first 6 years, where the obstetrician can be at home and he can see the labor tracing of the mother in the hospital to know if the baby's getting in distress and know when he needs to run and do the C-section or whatever. And this is just another arm of that. We've had teleradiology for years, where if you go in at night and you have a trauma and you're in the ER, you never see a radiologist. He's at home sitting in front of a $4,000 very high-def computer monitor, and he's reading your CT scan of your head, or he's reading an MRI, or it's just amazing that you can get that service. And he might even be in a different state. Oftentimes, those guys that work after hours are, and maybe they're in Texas, and maybe they're providing services for, a dozen different hospitals overnight. Anybody else? Other questions?
Ask away.
Still not legal in Missouri yet. They're trying to propose medicinal use for marijuana, but the way we're advising our clients is make sure that you have in your company policy and procedure handbook what your policy is regarding drugs and alcohol and illegal substances. If they're in a safety-sensitive job, I don't care if it's legal. I don't care if you're in Denver, Colorado. I don't want my bus driver driving my kids to school or my grandkids to school to be allowed to smoke marijuana and drive that school bus. And so, I think the laws are going to have to sort of evolve and address that. In states like Colorado, it's just going to be a horrible mess, I'm sure. But so far in Missouri, as long as you have a policy and procedure in place and your employees have signed off on that, and that's a condition of their employment with your company, you're safe, you're good with the law. And the work comp laws will still hold that if they're under the influence of something, that decreases their benefits and also decreases your liability. Okay, that's what I'd mentioned a little bit earlier. What we're trying to do is partner with various resources in the local area where you're going to be. Either you could have someone trained to collect the drug specimen, the urine specimen, and do the dipstick test, which is almost foolproof. I mean, all you're looking at is whether the pink lines appear or don't appear on the little wicks of paper that's connected right to the container. Or if we have like an urgent care in the area that will partner with us and say, okay, we're going to allow patients to just walk in only for a drug test, and they're not going to get charged an urgent care fee, or they're not going to be seen by the physician. All they're getting is just a drug test. So we're still in process of working those out in all the different communities. I know down at, for instance, Silver Dollar City, they're trained to do their own post-accident screen, and if it's a non-negative, then they're trained to fill out the chain of custody and then get those sent off to the SAMHSA-approved lab. So, it's seamless with them. And then the only thing I'm involved in is if they get positives, I do the MRO for their positives. But anyway, we're trying to work that out where whatever community you're in to see what resources we might have available where we can still get a drug test done or breath alcohol.
I would like to point out that in the state of Missouri, with your drug and alcohol reduction and work comp benefits, to reduce the benefits from alcohol, it's 0.08, the state legal limit. Alcohol is considered the proximate cause of the accident at that point. But as a physician, are there any particular levels of marijuana or other illegal substances that the medical industry and the judges, from your experience, look at as some sort of threshold, specifically on drugs?
There's not all we have are the cutoffs, number one, for the screening that determines a non-negative. And, for marijuana, it's set at 150, I think. And then for the cutoff for the confirmation, it's set at 15 nanograms. And, for every kind of drug, there's a cutoff for both screening and for confirmation. We don't have any specific cutoffs that say, okay, up to a marijuana level of 75, this person's not impaired, and beyond that they are impaired, like we do with alcohol. And then that even varies with alcohol, because if you're tolerant of alcohol, you might be driving a car at a 0.15. I wouldn't be driving a car at a 0.15. I'd be passed out asleep probably. But people that are tolerant, I've had people walk into an emergency room talking and upright at a 0.3, and that's unbelievable. I would probably be dead if I had a 0.3 because I don't drink like that. So, but anyway, that's quite variable with the individual. Now, the interesting thing about marijuana, a lot of people don't realize, THC is a fat-soluble alcohol, and the more you smoke it, the more you absorb it into your fat cells. So if you're a heavier person, you obviously have more fat cells, and if you're a more chronic user, you obviously have more saturation of your fat with THC. So if you stop marijuana today and you go drug test tomorrow, you're going to stay positive. I've had people stay positive as long as 6 weeks after they stopped smoking marijuana because they were like a 3-joint-a-day smoker for a year. They had so much in their system, it took that long to get it all out of their system where they'd have a negative test. Now, if you're naive to marijuana and you just smoke one joint one time, probably within about 48 hours, you're not going to test positive anymore because it's in and out of your system. You didn't absorb a lot of it in there. And, other drugs have different rates of metabolism, and that's why it's good to have a medical review officer that you can consult with if you have questions like that, because there's a lot of detail there that has to be understood by the doctor that's interpreting those tests. Some things are really fast out of your system. For instance, cocaine, after 24 hours, you won't see a trace of that because it metabolizes very quickly. Meth is variable, again, on how big the dose was and also how pure the meth was that you bought. If you got homegrown, made down here in Taney County, what they call 417, it might not be that good, really kind of raunchy meth. If you get the really good stuff, the crystal ice that comes out of Mexico, that's good stuff, very potent. Same thing with overdoses. You use the more potent stuff, you're at greater risk of overdose. But that's quite variable on how much did they actually take in, what was the route of, did they snort it, did they smoke it, did they melt it down and shoot it IV? So all those things make a difference as to how long it's going to be in your system. That's automatic in the screening cups that we use. They test for the pH, and if it's a pH incompatible with human fluid, then they'll let us know. That turns out to be a positive screen if it's not compatible with human urine. They also test for oxidizing substances. Some people have gotten savvy enough, they've done a lot of research on the internet, and they know how to game these tests, so they'll pour something in there. Of course, we look at the color. We look at the temperature. It's got to meet all those parameters in order to be a valid test. And if they don't meet the parameters, then they have to come back and do a witnessed drug screen, and it has to be the right temperature. And we catch those all the time, the ones that are too cold. And we caught one last week that was too hot because they were using one of those little chemical hand warmers to keep their specimen that they'd bought or somebody given them. They thought they had a clean urine, so they kept the hand warmer in their pocket. And then when they went in the bathroom, they poured it out of the baggie, But it was real hot, so. We got them in too quick. They weren't ready for how quickly we got them in.
He didn't have a fever?
No, they didn't have a fever. Yeah, we checked the patient's temperature too. So.
Out of curiosity, And again, you're welcome and encouraged to ask Dr. Cross, as an occupational medicine physician with a lot of years of experience, anything to do with that process. I know there's probably not you haven't seen, but specifically on the drug and alcohol, is that an indication from the physician at the first visit that that may or may not be a proximate cause or contributing factor in the injury, or is that something that is usually made later down the line?
That's usually a retrospective diagnosis. You know, after you've seen the patient, you've done your initial evaluation, because the only thing you'll have is maybe a notation on the paperwork that this urine got sent out. Well, that's a red flag to us. It said, well, that means they probably had something in their urine that's going to come back, but we can't do anything until we have the confirmation, because the confirmation is what used legally to make that determination of the presence or absence of a drug, and also the quantitative amount. A lot of people don't realize those little screening cups that you use, you know, there's a little wick in there, and the urine flows up through the wick, and then there's little monoclonal antibodies on there. So if it turns pink, then it was not present. If there's no pink line, then it's possibly present. And then when we see the absence of a pink line, we say, well, this is a non-negative test. We don't ever call it a positive, because it's not a positive. You know, it's a non-negative test. So then we package that urine up and we send it off with the seal on the top to a SAMHSA-approved lab. And then once it gets to the lab, they do two different kinds of tests on it. They do something called a gas chromatography and a mass spectrometry. And they can actually quantify how much of the drug is in that amount of urine that they test. So that is what is the evidentiary result, not the screening. You can't ever do it. You can't fire somebody on the basis of a screen. You can't withhold benefits on the basis of a screen. You have to wait till the confirmation comes back, and you also have to wait until the MRO has reviewed with the client the positive result. Because if they have a legitimate reason to test positive or something, he's going to report that to you as a negative drug test. And you can't hire or fire somebody or withhold benefits, because then you're going to have a lawsuit for wrongful termination or, you know, inappropriate withholding of benefits. Yes, ma'am. Are you using mouth swabs for alcohol? All for drugs too? Once again, it's a screen. If you look at the package inserts on all the different types of screens, they'll give you a predictive value percentage. The urines are really high, way up in the high 90s. As you get toward some of these other screens, they start to drop off a little bit. Alcohol is still a good screening test, but once again, if they get a non-negative on the swab, then you should take a urine. You should send the urine in. Anybody else? Appreciate your attention, and I'm always available. You can always call the 269 comp number. Michelle Beckemeyer is with us. She is our coordinator over occupational medicine, and she'll be here along with Rebecca, and they'll answer questions about OcMedStat or about our one-line number of access into our system, and be happy to try to do that at any time. If you decide you want to have somebody come and talk to you on setting up OcMedStat, we have people that will do that too, and give you an idea what the costs are going to be, and also about what the equipment involvement is and how we can do that efficiently. We actually have a contract pending for 90 additional companies. You saw about 6, I think, on that one slide, and we're getting ready to have 90 companies join us. So it's just going to really grow.
Very good. Thank you very much.